Hello, and welcome to ID Talk, answers from infectious disease experts. I'm Dr. Scott Olson, a pediatric infectious diseases specialist at Banner University Medical Center in Tucson and associate professor of pediatrics at the University of Arizona College of Medicine. Along with Dr. Nathan Price, I am the AzAAP Infectious Disease and Immunizations Co-Medical Director. And if you're looking at the thumbnail on the podcast, Dr. Price is the good-looking one on the right, and I'm the other one. This podcast has been created to answer questions from our chapter members about anything and everything infectious disease and immunization related. Thanks for tuning in today. Question number 1 states, post-pandemic vaccine hesitancy is still very prevalent. How can we explain vaccines to parents that are undecided on vaccinating their child, and what are the most important vaccines to administer? This is a great question, and I particularly think it's pretty timely at this point. Unfortunately, I think we all understand that vaccine hesitancy has been a concern that was accelerated over the course of the COVID pandemic. We know that before the COVID pandemic, immunization rates among young children were about 95%, or what we would expect to maintain herd immunity within that cohort. A recent MMWR report from October 17th, however, highlights the increasing number of kindergartners entering school with vaccine exemptions. Interestingly, what they highlight is that over the course of the last several years, we've been seeing a decline by about 1% per year annually in kindergartners who enter with complete vaccination. Currently, the U.S. estimates that about 3.3% of kindergartners enter school with exemptions, and the majority of those exemptions appear to be either religious or personal exemptions, as medical exemptions are quite rare among children. The rate of exemptions is just above 3%. They did notice that only about 92% of children were entering kindergarten fully immunized. The study in MMWR then also goes on to look at rates of immunization among kindergartners at a state level, and we certainly see pretty broad variation across different states with regard to how well we are immunizing our young children. Arizona, for example, has the 5th highest rate of exemptions in the nation. Within Arizona, they found that 8.5% of kindergartners were entering school with some form of exemptions. And because medical exemptions in the state are at less than about 1%, and religious exemptions are not approved in Arizona, that means that the majority of them are due to personal beliefs, which I think has been seen across the country over the course of the COVID pandemic. Additionally, they looked specifically at the individual vaccines and noticed that only 89% of kindergartners in Arizona that they sampled were up to date with 2 doses of the measles vaccine in advance of kindergarten attendance, which for those of us who remember our basic vaccinology, we really want to try to maintain that vaccine rate at about 95% to prevent any sort of rapid spread within the community if measles was imported. So a rate of 89% is really discouraging at this time. Additionally, then they looked to see if we were to capture all of those kindergartners who were unimmunized but did not have an exemption, meaning that perhaps they just were not able to get into clinic in advance of kindergarten start. Unfortunately, they saw that still, even with capturing all of those patients, we would only be able to achieve 92.8% of kindergartners being up to date on their vaccine coverage in advance. Again, we have a long ways to go and a lot of heavy lifting to do, which for the most part falls on the shoulder of our community pediatricians. So I think in general, all of us pediatricians know that we need to figure out a way to do a better job of messaging the importance of vaccination to hesitant parents and to convince them that these vaccines are both safe and effective at preventing preventable infections within the pediatric population. A recent study in MMWR from August of this year used modeling to estimate the impact of routine immunization within the United States. They estimate that among 117 million children born between 1994 and 2023 in the United States, routine immunizations have prevented 508 million lifetime cases of illness, 32 million hospitalizations, 1.29 million deaths at a net savings of $540 billion in direct costs and $2.7 trillion in societal costs. And I think all of us in medicine understand the importance of immunizations, but it's a question of how we as providers can communicate with vaccine-hesitant patients, parents, and families to really show them how important these vaccines can be in preventing illness in their children and their communities. Here is where I have to admit that as a pediatric infectious disease subspecialist. I'm not necessarily the frontline provider who's having these conversations with parents. So I can highlight a little bit here some of the approaches that are recommended, but I have to admit that those of you in the community probably have a better understanding of what's been working for you in your practice. Though I am unaware of any head-to-head studies comparing these different approaches, there are several different messaging systems or approaches that have been looked at and have some evidence behind their benefit. And I think that my recommendation would be just try out a few of these different approaches and figure out what you feel most comfortable using when you are communicating with these hesitant parents or families. Some of the approaches to consider include the presumptive approach, where you recommend the vaccines in a way that you presume parents or families are going to be accepting them. And there has been evidence that this approach is associated with higher rates of vaccine uptake. Additional ideas include motivational interviewing. I have to admit that I think this is probably what I use most often, where you try to take the time to engage the family to figure out what exactly is their concern with vaccinations, and then you target your communication to whatever it is that they may have concerns about. Tailored communication then is often paired with motivational interviewing, where once you identify what the family's main concerns are, you use some either pre-established forms or education materials that speak specifically to the concerns the family has. Additional ideas that I think are always good in general practice include things like taking time to build trust with the families, using non-confrontational dialogue, and focusing on some educational interventions in general that you can apply across your pediatric practice. With regard to which vaccines I recommend for those who are vaccine hesitant, I have to admit that I would probably say start with those that the family is willing to get and use that as a way to bridge into discussing the immunizations that they may be hesitant to receive. Then with regard to which specific immunizations I recommend, well, I have to say I think they're all important, right? That's why we recommend them, but I would say you really want to focus on those that are still infections that infants and young children in the U.S. could be exposed to. So those things such as pneumococcus, diphtheria, tetanus, pertussis, and then hopefully over time by building trust, you can convince the families to then consider all of the other childhood immunizations such as measles, mumps, rubella, and varicella. As I mentioned earlier, I'm sure you in the community are having these conversations with families more often than I am on my ID practice. So if any of the listeners have strong thoughts on what they feel works in their practice, go ahead to respond to the email that I'll be including at the end of the podcast. All right, so that was a lot for question 1. I think we're off to a great start, so let's get to question 2. Question 2 states, there is a growing concern for whooping cough in the United States. Can you review the Tdap vaccine schedule? I think this is a great question and another really timely one for this time of year in 2024. During the pandemic, we did see decrease in number of cases across the country of pertussis, and that was most likely due to mitigation measures during the pandemic, such as social distancing, remote schooling, and masking. Of course, since we relaxed all of those measures, much like other respiratory illnesses such as RSV and influenza, we unfortunately have been seeing a rising number of cases that has come close to either the pre-pandemic or even higher levels of circulation in the last year. In the U.S., typically, there are about 10,000 cases reported each year before the pandemic. However, in 2024, we're seeing that there's been a rising incidence of pertussis throughout the country with some pockets of increased activity. As of the calendar week 40, which is October, there have been 5 times as many cases nationally compared to 2023, and that the incidence appears to be higher than 2019, just before the COVID pandemic. That may sound scary, and it's certainly something we want to be aware of, but I think we need to remember that levels of pertussis circulation in the community are still well below the rates of infection that were occurring before routine immunization against pertussis. Immunization was first introduced back in 1948 when the U.S. was experiencing around 200 to 250,000 cases annually, and whooping cough was a major cause of pediatric mortality. Thankfully, immunization led to a dramatic decrease in the number of cases that we were seeing in the U.S. annually, and after routine immunization was instituted, there were about several thousand cases per year across the country. However, the initial vaccine preparation was a whole cell killed pertussis vaccine, and due to concerns for increased reactogenicity, or the amount of inflammation that occurs locally or systemically as a result of vaccination, in 1994, the whole cell pertussis vaccine was replaced with Tdap, and the little a before the P signifies that the newer vaccine preparation is an acellular pertussis vaccine using bacterial antigens as opposed to whole cell killed preparation. The newer vaccine includes pertussis toxin, FHA, peractin, and fimbriae type 1 and 2 as their antigenic components. Unfortunately, while the newer preparations didn't cause as much inflammation or reactogenicity, the acellular pertussis vaccine has been shown to lead to waning immunity the longer you are from immunization. And as a result, there have been increasing numbers of breakthrough infections in immunized individuals, and that in part has led to increased rates in pertussis circulation in the community since 2012, when about 48,000 cases were reported. When we look at the vaccine efficacy of the pertussis products that are available, Big D TAP protects against illness in 98% of patients within the first year after the final dose in the series, and follow-up studies have shown that at 5 years, about 7 in 10 children are protected. Again, within that first 5-year window, we know that immunity against pertussis wanes. However, it's encouraging to know that at least within the first several years, when children are most at risk, they're fairly well protected. When we look at the adolescent and adult preparation, or Big Tdap, we know that about 7 in 10 people demonstrate evidence of protective immunity within the first year, and unfortunately it wanes to only about 3 to 4 out of 10 people about 4 years after the immunization. And in large part, this is what has driven increasing circulation among adolescents and adults, who may not get as sick as the younger individuals, but certainly is concerning because it allows for continued propagation within the community. So that's a lot of background, but again, the question was simply asking, can we review the Tdap vaccine schedule? Of course we can. So, the current pertussis vaccination recommendations from the CDC call for a primary 5-dose series of DTaP at 2, 4, and 6 months, with boosters at 15 to 18 months, and again at 4 to 6 years before enrollment in school or group care. Then with regards to adolescents and adults, the recommendation is for a booster with either TD, or tetanus diphtheria, or the Tdap vaccine every 10 years, primarily to protect individuals against tetanus. However, if you're including the Tdap, of course, you then have the added benefit of hopefully protecting that individual and their loved ones from pertussis. Additionally, I think it's important to remember for those families where a mom is expectant that pregnant individuals are recommended that they receive 1 dose of Tdap with each pregnancy. And again, that's because we know that moms who are immunized in the 3rd trimester transmit protective antibodies across the placenta to the infant, keeping them protected in that first 2-month window where they're at high risk for severe disease but are not yet able to be immunized. Moving on to question 3. One provider writes, is long COVID less likely in children who have stayed up to date on their COVID vaccines? What can parents with children experiencing long COVID do to minimize their symptoms? Lots of great, timely questions today. This is a tricky one. I think one of the questions is easy to answer, and unfortunately the other one is a lot harder. Since the beginning of the pandemic, we've really grappled with the conundrum of long COVID. I think a lot of people listening are familiar with the idea of long COVID, but it's worth going through quickly before we talk about preventing and managing. Long COVID is a post-infectious phenomenon where some patients experience prolonged symptoms that can be vague and heterogeneous, such that it's likely to be underreported. So any numbers that we see come out estimating the number of patients with long COVID are probably a little low compared to the reality. The most common symptoms that patients associate with long COVID include brain fog or confusion, prolonged dyspnea, GI dysfunction, generalized pain, and sometimes debilitating fatigue, which follow acute infection. And these symptoms can be severely disruptive to both the lives of patients, but also to the families of the children that we see with long COVID. Now, the pathophysiology of long COVID is really poorly understood at this point, but most likely it's a post-infectious phenomenon related to immune damage from the host inflammatory response that occurs with the acute infection as opposed to the belief that there is ongoing viral replication causing these symptoms. When I talk to providers or families, I oftentimes tell them that though we're not as familiar with long COVID, historically these are the types of prolonged post-infectious symptoms that we can see with other acute infections such as Epstein-Barr virus or Lyme disease. Now, because there's no evidence-based therapy that has really been shown to be effective in managing the symptoms of long COVID, this is definitely one of those situations where an ounce of prevention is worth a pound of cure. Immunization has actually been shown to protect not only against severe COVID disease, but studies have also shown that it does protect against the development of long COVID after acute infection. There have been two recent large studies in particular that I think are worth referencing here. The first is an adult study that was published in Vaccine back in 2023. This was a systematic review that showed a protective effect of vaccination against long COVID with an odds ratio of about 0.64 and a confidence interval that did not cross 1. Again, that was mostly in adult patients, but there was a more recent study that was recently published in April of this year in Pediatrics that looked to estimate the vaccine efficacy of COVID vaccination against the development of long COVID symptoms in children between 5 and 17 years old. In this study, the incidence of probable long COVID was 4.5% among all individuals, with an incidence of actual diagnosed disease in 0.8%. When they compared the rates among immunized and unimmunized, they showed a vaccine efficacy within 12 months of immunization was about 35% against probable and 41% against diagnosed long COVID symptoms. When they looked specifically at subgroups, they noticed that there was a higher vaccine efficacy among adolescents of about 50% versus younger children of 5 to 11 years old, where vaccine efficacy was about 23%. Unfortunately, they did note that the vaccine efficacy decreased over time among all children at 18 months of study, to only about 10% among all individuals. But though that number doesn't sound great, I would argue that because long COVID can be so debilitating, anything we can do to prevent it is still a great thing. Now, if you'll allow me, I'm just going to take a quick detour to brag for a second. As I was reviewing this paper again, I just happened to notice that the third author was a MPH student who worked with me several years ago on a flu vaccine study. So, Katie Hirabayashi, if you're out there listening, keep up the great work. Now on to the trickier question of what do we do with patients who do have symptoms of long COVID? And unfortunately, I think I, like lots of the medical community, don't have a great answer at this point. There have been some experimental studies looking at approaches such as high-dose immunoglobulin therapy and other experimental drugs that are in the pipeline. Now, a lot of these studies have used adult patients, and I would say that the data so far is not robust enough that I would recommend at this time for use in pediatric patients, but this is an area in medicine that I think a lot of us are looking to expectantly to hopefully have some answers in the future. And hopefully if those are in the near future, we can talk about them here on ID Talk. As for now, I would probably recommend an approach that I've used in the past with patients of mine who are experiencing similar prolonged symptoms after a viral illness like mononucleosis or Lyme disease when I was practicing in Wisconsin. For those patients, I often offered a combination of cognitive behavioral therapy to help them build coping mechanisms and coupling that with physical therapy specifically for reconditioning purposes. Now, this may not work for every patient, but I think it's at least a starting point to work with families until we hopefully have some more targeted therapeutics in the future. All right, on to question 4. One provider asks, what is the recommended time frame for children to get the updated COVID booster vaccines post-infection? For example, if a child had COVID in August, when should they get a COVID booster vaccine? Well, this is lovely. I don't need to do a lot of talking this time. My colleague, Dr. Nate Price, on the last ID Talk podcast, did a wonderful job of going through the current CDC recommendations for COVID immunization. So first off, I would recommend that if you haven't, I would go back and listen to that wonderful podcast. With regard to the specific question of when we should immunize individuals who have recently experienced an acute COVID illness, the CDC recommends that you can consider delaying vaccination by about 3 3 months after symptom onset, or positive test if the infection was an asymptomatic diagnosis. Now, this is not because there are any concerns for safety if you immunize too early. It's simply that we know that individuals after an acute COVID illness are unlikely to have a recurrent infection within that first 3-month window, presumably because they still have high circulating levels of antibody. So you don't need to necessarily within that window. And on to our fifth and final question of the week. Although I guess this is more of a statement than a question. We had a provider write in who was hoping for a little bit of insight because she had noticed that in her small practice, she had a number of adolescents or school-age children who were presenting with acute respiratory symptoms that were suggestive of something more than just a viral illness. And in particular, a few of those patients had tested positive for mycoplasma. So she was wondering if we could sort of speak to the incidence of mycoplasma nationally and if we knew anything locally. The first thing I would say to this provider is kudos on the wonderful clinical suspicion. Mycoplasma is not a reportable disease, so this makes surveillance a little more difficult. That being said, the CDC does still track mycoplasma activity using both data from the National Syndromic Surveillance Program and data provided by the manufacturer of the BioFire respiratory PCR panel. Typically, we see about 2 million cases annually in the US, and that's likely an underestimate because many of these infections go undiagnosed. We know that outbreaks can occur in crowded settings, such as schools or among military recruits, and in particular, these outbreaks can be prolonged in large part because mycoplasma has a very long incubation period of 1 to 4 weeks. There was decreased mycoplasma activity throughout the COVID pandemic, but starting in 2023, we began seeing an increase in number of cases across the U.S. And then in 2024, there has been a bigger increase in cases beginning in the late spring and the early summer. And this started at a low baseline that we had observed since the beginning of the COVID pandemic. But unfortunately, like with lots of other respiratory illnesses, those number of cases have been rising fairly dramatically in the last year. The CDC is continuing to track the mycoplasma transmission within the U.S., but I suggest you use your clinical intuition, and especially if there seem to be pertinent exposures within a group environment. I would say if it seems like pneumonia and they're the right age, you want to make sure you're thinking of mycoplasma. And if you have the ability to test, it would be useful from a tracking purpose just to have that positive result, though, of course, it's not necessary to make the diagnosis of pneumonia, as we all know, since that's a clinical diagnosis. So that is it for ID Week for the week of October 21st. Thanks again for listening. Remember, AzAAP members can submit questions for future episodes to id@azaap.org. The AzAAP would like to acknowledge the generous support of this podcast by the Arizona Department of Health Services through the Title V Maternal and Child Health Services Block Grant funding. For more information and resources related to infectious diseases and immunizations in Arizona, or to become a member, visit azaap.org. As always, thank you for these interesting consults, and we'll see you again next time on ID Talk.